Welcome to the COVID-19 vaccine webinar aimed at children, parents, educators, and everyone else school-related. This event is being put on by Clackamas County Public Health, and outreach has been specifically aimed at populations involved with the county schools. I'm Dylan Blaylock with Clackamas County's Public and Government Affairs Department, and I'll be coordinating questions and comments for tonight's meeting. Joining us for the hour is Dr. Sarah Present. She is the Clackamas County Health Officer, which makes her the Chief Clinical Public Health Advisor for Clackamas County. My thanks to you for being here, Dr. Present. Here's how tonight's going to work. For the first half hour or so, Dr. Present will give a presentation on the COVID-19 vaccine. She will cover vaccine basics, common myths versus facts, county-specific vaccination data, and what to expect if you go and get a vaccine. After she finishes her presentation, which will probably be sometime from 6:30 to 6:35, I will relay health-related questions that have been submitted to us via the chat function. You can ask those questions at any time, but again, I will get to them during the last 20 to 25 minutes or so. To pose your question, simply chat it to us. Please go ahead and use the chat function at the top or bottom of your Zoom, depending on your device. We do ask everyone to please keep your questions to under 30 seconds when read, as we would like to get through as many questions as we can. The longer the question, the less chance I have of relaying it. So again, we are trying to get through as many as we can. And I'll repeat these instructions again just before we start the question and answer period. And with that, we welcome Dr. Present.
Thank you so much, Dylan, and thank you everyone for being here. I'm really excited for this opportunity to get to provide some education from my standpoint, and I really want to be careful to be open and transparent and be really clear about what we know and what we don't know around vaccines. We have learned a lot about vaccines in the last several months as more and more people get them. And I know that there's still a lot of questions, and there's a lot of bad or wrong information out there that could be really scary. So I thank you for joining me. I really want to take this opportunity to address some of these current concerns and talk about what the science really says. So as Dylan let you know, I am the Public Health Officer for Clackamas County. So as Public Health Officer, I give medical and clinical advice on anything having to do with public health. I work really closely with our COVID response teams. I'm also a family doctor. I am in primary care at the Clackamas County Beaver Creek Health Center. So I see adults, children, pregnant women, older people as well. And I'm a mother of a 10-year-old who is anxiously excited and waiting the chance to get a vaccine. And I'm an auntie of a high school senior. And so I've been able to talk with her and a number of her friends about their concerns and some of the things that are being passed around as far as questions. So I hope to address some of those and really explain what's happening, and we'll go ahead and get started. All right, Dylan, if you can go to the next slide. So I admit, like I said, I like transparency. I'm going to admit we have some boring slides, but they're really informative. So I'm going to just walk through them with you. This slide is some statistics around the age groups of people who have had COVID-19 disease in the state of Oregon. The left-hand side, these bar graphs, the orange is people who have been hospitalized. The orange is people who have not been hospitalized. The blue are people who have been. And the gray is where hospitalization status is unknown. It's a little bit more clear in the table on the right. We can see that if you're over 80 years of age and you get COVID-19, you have almost a 1 in 3 chance of ending up in the hospital. We can see that hospitalization and similarly death increases with COVID-19 as you get older. The younger age groups, all of them, there are risks of hospitalization and death, just regardless of your age. The younger age groups do not tend to get as ill. That's true. They tend to not be hospitalized as often. They tend to not die as often. And it's really more focused on those who do have underlying chronic medical conditions, which happens throughout the age groups. But we can also see on the left that the largest age group to have COVID-19 disease is young people in their 20s. followed shortly by 30s, but the 10 to 19-year-olds are closely behind there as well. The numbers of people who've gotten COVID-19 disease in the older age groups are smaller. What this tells me is it's really important that we decrease the spread in our younger populations to really protect the lives and livelihoods of our older populations, including themselves, but we really need to think of it as a community as a whole. All right, next slide, please. So this is another one of those, looks boring, but there's a lot of really interesting information on this slide. This is a graphic of the vaccine development process. So there is a lot of concern that the COVID-19 vaccine was developed too quickly. It's a new medicine, it's scary, and people think that that means that there's increased risk. This slide explains why that's not the case. So the Pfizer vaccine, which is what is available for adolescents and people under the age of 16 or 18, is an mRNA vaccine. mRNA vaccines have been studied for almost 20 years. It's not new science. It is new that the mRNA vaccine science is being used in the COVID-19 vaccine on a widespread basis, but the science is not new. So the top little graphic here is a traditional pathway for a vaccine to be developed. You have some preclinical information. A lot of that has to do with animal studies. A lot of that has to do with just bench science, trying to figure out mechanisms to protect humans from certain bacterial and viral agents. Phase 1, once a possible vaccine is developed, phase 1 is its first use in humans to determine safety, dose, and tolerance. Phase 2 is a larger scale, so a lot more humans, to determine the efficacy. So we say here that define immunogenicity and safety in larger numbers of people. It's really less about how much you're going to give and what to expect, and more about how well it works. And then phase 3 is more about how well it works. Phase 1 and phase 2 really establish safety. Phase 3 is focused on efficacy. It does not go into phase 3 trials until it has been determined to meet very strict safety criteria. Typically, and then it can be registered. And then phase 4, we are always monitoring every vaccine that we give to any humans. If safety concerns do end up coming up, we are always monitoring and we catch it and address it. So typically, to go through this whole process and be registered as an FDA-approved vaccine, we're looking at 4 years or more. This pandemic needed us to have an answer faster than that. We needed a tool to stop the spread of this pandemic so that we could come out of our lockdowns, so that we could get back to normal life. So what happened is that phase 1 and phase 2 and even phase 3 were kind of put closer together. And really the only reason that this happened, and it doesn't happen in normal vaccines, is because the pharmaceutical companies had money. The Trump administration realized the importance of a vaccine to get us out of the pandemic. This is our main tool to stop the spread of this disease. And so they assured the pharmaceutical companies that they would get paid. Therefore, they were able to complete the entire research on the vaccines in a shorter time frame. No steps have been skipped. You can see here on the bottom slide that emergency use authorization was offered before what would normally be the end of phase 3. But again, that is not focused on safety, that's focused on how well they continue to work over time. And we can talk more about that in question and answer around why we're doing booster shots now, because there's suggestions that some people may have decreasing immunity over time. But the safety of a vaccine the safety flags of any vaccine start within the first 3 months of getting a shot. After 3 months, the vaccine is not in your body anymore. And the chance of having any adverse reactions after 3 months after getting a shot is near zero. It's incredibly, incredibly small. And I'm going to talk a little bit more about that on a upcoming slide. Next slide, please. Okay, so what do vaccines do? And again, I'm going to focus on the Pfizer vaccine because that's the one that is available to 12 to 17-year-olds. We do not have another vaccine that's authorized for that younger age group. So I'm going to focus on the Pfizer vaccine. What what the COVID vaccine does, but most vaccines do, is teach your body how to recognize and fight the disease that they are protecting you from. So this COVID-19 vaccine teaches your body how to recognize and fight the coronavirus that causes COVID-19 disease. It contains messenger RNA, so it does contain some genetic material, but that is really like an instruction manual. It teaches your body how to make a harmless protein that looks like a protein on the coronavirus. We call this the spike protein. Your body responds to that protein and creates disease-fighting cells and antibodies that then, if you actually have the disease presented to you, your body can fight it off and not get sick. So once you have the vaccine, your body sees the coronavirus, recognizes that protein, which we call the spike protein, in the future if it's presented to you, and it's ready, and your immune system is ready to protect you from getting ill. They do not contain the coronavirus themselves. It's only a very, very minute part of genetic material that's similar to coronavirus genetic material. It does not contain the virus and absolutely cannot give you the virus. You cannot become ill with COVID-19 from getting the vaccine. The other important thing, it can be scary to think about genetic material. This isn't new science. I tell you again, there are many, many different therapeutics that use this similar science. They do not get into your cell in a place that it can change your DNA or your genetic material. It doesn't go into the nucleus of the cell where your DNA lives. And I'm going to show you a picture of that on the next slide. And then we're going to get to some more interesting slides. Go ahead, Dylan. Next slide. All right, so here on the right side is a picture of how it works. You can see that vaccination on the lower left, it goes into your cell. And you can see the cell in the bottom right corner of this picture. It is an envelope of proteins, fats, potassium, nothing that actually is living, but something that your body is able to bring into the outside of the cell. Once it's in there, it releases that little bit of genetic information. You can see that greener circle down in the bottom is the cell's nucleus. That's where our DNA is, our genetic material. It does not go in there. It does not affect our genetic material whatsoever. What it does is it uses the manufacturing system that is in the outside of the cell. So the outside of the cell has all these tools to take genetic material and turn it into proteins. So it takes this little bit of instructions and actually puts a spike protein on the surface of one of our own immune system cells. And then our immune system can respond to that. It responds in a way that is not as intense as the disease itself. So this is a very typical way of getting immunity from any of the vaccines that we have. Vaccines introduce a very small, minute portion of some bacteria or virus that gets our bodies to recognize it in a way that when the real threat is presented to us, we can fight it off and not make us ill. It actually comes from long-held traditions of homeopathy. It's really the same thing. You take a little bit of a bad thing so you can build up a response so that when you get a big bit of that bad thing, you respond to it and you protect yourself. So here is a long list of what's in the Pfizer vaccine. It's actually not that long when you look at a lot of medications that we use and a lot of vaccines. It does not contain pork. It does not contain eggs or egg parts. It's not grown in eggs. There's no latex. And there are no preservatives, which is part of why we have to keep it refrigerated. So there are no harsh chemicals that people can respond to who respond to preservatives. I also want to take a moment and say that there are absolutely no fetal cells or fetal cell parts in our vaccines, in any of them. I know that that is one thing that has come out with a lot of confusion, and a lot of people are claiming that there are. There are not. I'm going to talk about fetal cells for just a second here. Fetal cell tissue lines have been around for 30, 40 years, and certain cell lines are still being used in many, many, many medications and vaccines. It's not part of a fetal cell, but it is a long descended tissue culture line. To make vaccines, to make many medications, you have to have the living cell to either grow it in or to test it on. The Pfizer vaccine was never grown in fetal cell tissue whatsoever. Because it has this mRNA with the protein fat capsule, it does not need to grow in live cells like that. They have used some to test it. That's true, but it's not grown in fetal cell tissue. Okay, next slide, please. So back to why we need to vaccinate adolescents. We all have learned that the older you are, the more at risk you are. With the Delta variant that we've had that has caused our most recent surge, younger people who do not have underlying conditions have also been getting severely ill. Adolescents have been getting very ill. It's a more infectious viral strain, and it causes worse symptoms, we're finding in many people. We're really lucky that many of our elderly were vaccinated before the Delta virus came into our area, because we would have had many, probably thousands more deaths if we did not have the numbers of older people vaccinated that we did at the time, and younger people too. This study came out just yesterday from the CDC in a morbidity and mortality weekly report. So this is how the CDC gets information out to us, that showed a 93% reduced risk of COVID-19 hospitalization amongst adolescents. So people 12 to 18 years old. Having a vaccine decreased your risk of getting hospitalized by 93%. And this study, I'm going to be transparent, it was a small one. There were only 180 kids that they looked at who were hospitalized, because kids tend to not get hospitalized as often. We know that. However, of those 180, only 3 of them had actually been vaccinated. Of those 180 who became hospitalized, 16% of them needed to go to the ICU and get life support. None of them were vaccinated. They were all unvaccinated who had severe illness. There was also a study from Israel very recently that looked at over 130,000 12 to 18-year-olds. So a much larger study. And it actually showed that the Pfizer vaccine was 93% effective against having symptomatic infection at all. So we know that some people who are vaccinated can get the disease anyways. We do have breakthrough cases, but we are also finding the Pfizer vaccine, and the others as well, are incredibly effective at preventing any illness, not just the hospitalization and deaths. Next slide, please. So on May 10th of 2021, so it's been about 5 months now, a little bit more, the FDA granted emergency use authorization for the Pfizer vaccine to include ages 12 to 15. Prior to that, it was 16-year-old and up, and it has received a full FDA authorization for that older age group because we have a full year's worth of efficacy data. That's really the reason to wait between the emergency use and the full FDA approval, is just time frame to make sure that it still works a year, 2 years later. The initial clinical trials of Pfizer showed 100% protection against COVID-19. So nobody who got vaccinated with Pfizer got COVID-19 in the clinical trials of Pfizer. This was before the Delta variant came, and we know that there's an increased breakthrough rate because it's more infectious, but still, it's incredibly effective still. It also showed really favorable safety and side effect profile. So we talk a lot about the side effects. A lot of people feel kind of cruddy after the vaccine. A lot of people don't. Many people have no side effects from the vaccine at all. Actually, the majority don't. But amongst adolescents, nearly 90%, so 79 to 86% of them had a sore arm the next day. After I got my vaccine, my arm hurt a lot. I got my flu vaccine recently. It didn't hurt as much. So it hurt, the COVID vaccine hurts a little bit more. 60 to 66% of them felt tired. 55 to 65% of them had some headache. But these all went away within 1 to 3 days. There were, in the trials, no vaccine-related serious adverse events. So I'm going to say again, when I got my COVID vaccine, I did feel kind of cruddy. I had a headache, I had brain fog, I had fatigue. I said, you know what? This is what my patients who have had COVID sound like they feel, but I didn't have the respiratory symptoms. And my symptoms went away in 2 days. And I was so grateful that I could feel how awful that felt and know that I wasn't going to have to feel that for weeks to months because I was not going to get severe illness from COVID-19. Next slide, please. Again, these are some of the side effects that are common, but they're common for most vaccines, not just the COVID-19 vaccine. I also took my daughter to get a flu shot last week. She gets a mild fever every year after she gets the flu shot. I'd much rather her have that than to actually get the flu and be out of school for 1 to 2 weeks and potentially get severely ill. So common side effects are that sore arm, headache, mild low-grade fever or chills, tiredness, and muscle aches. They typically last for a few days and then go away. You're not supposed to get respiratory symptoms from the COVID-19 vaccine. If you have these symptoms and you have respiratory symptoms, you should get tested for COVID because you may have been exposed before you got vaccinated. I want to say again that long-term side effects from vaccines are near nothing. It's only really theoretical, like minute, very, very, very incredibly small chances of anything showing up after that 3 months. So after 3 months after vaccine, the safety has been established. Really, the vaccine goes into our body, like I showed you. Our own cells make the immune response, and all of our own immune cells regenerate in about 2 weeks. So after 2 weeks, those cells naturally die, and there is nothing left of the vaccine in your body. There's only your own immune response. So after those 2 weeks, maybe up to 3 months, there's absolutely no way that the vaccine is still causing any reactions in your body. It's only your own immune system and how it's working. Next slide, please. I'm going to take a sip of water here real fast. Thank you. It's late in the day. I'm getting parched. So the next few slides, I'm going to go through a couple of common myths, and some of them I've touched on already. So myth number 1, the COVID vaccines were developed too fast and are not safe. I think I talked about that in probably more detail than you want. But all of the authorized vaccines have undergone thorough and transparent testing with tens of thousands of participants to ensure their safety. I looked today and I think there are nearly 7 billion vaccines that have been given around the world at this point. That's actually much more well studied, especially in the first year or two of a vaccine, than any vaccine I've ever heard of before. The technology that was used to develop the new mRNA COVID-19 vaccines is not new. They were developed with this necessary speed and efficiency in order to address the emergency nature of the COVID-19 pandemic. So while they were developed relatively quickly, there were no cut corners or compromises in the quality or safety of the vaccines. Next slide, please. So another myth is around fertility problems. There's a concern that COVID-19 vaccines can cause future fertility problems in teens and adolescents. The fact is that there's absolutely no scientific evidence that the COVID vaccine causes any complications for those who are going through puberty, those who are pregnant, or plan to become pregnant. There's actually building evidence against any concern of changes in fertility. There was a study that came out just yesterday looking at miscarriage rates in women who were pregnant in their first trimester getting the vaccine or not. No difference. The vaccine has been recommended by the American American Pediatrics Association, as well as the American Academy of Pediatrics. It's also been strongly recommended by the CDC and American College of Obstetricians and Gynecologists for women who are pregnant. While I'm talking about organizations, I also want to let you know that the NUNM, our naturopathic university in Portland, Oregon, strongly recommends vaccine, as well as other naturopathic groups. And I want to note that pregnant women who get COVID-19 are twice as likely to be admitted to the ICU if they get COVID-19 when they're pregnant than non-pregnant, and 70% more likely to die. So they are also more likely to deliver prematurely, have stillbirth or miscarriage if you get the COVID-19 disease while you're pregnant. So there's no risk, and there's building evidence that there's no risk to the vaccine during pregnancy. There is high risk of getting the disease during pregnancy. But also looking at fertility, there's some evidence that the COVID-19 disease decreases sperm count in men. So the disease can affect fertility. It also causes a lot of inflammatory and clotting issues that could potentially affect fertility in women. I know that this is a concern because some women do have changes in their menstrual cycle after they get a vaccine. And we have to note that menstrual cycle changes are common in response to stresses, in response to inflammation. And just like I had really bad side effects for 2 days after I got my vaccine, it's possible that your own immune response and the inflammatory response that naturally happens in order to protect you from getting severely ill, that's mild, can cause some mild menstrual irregularities in 1 to 2 months afterwards. The studies have shown that those who have early menstrual irregularities go back to being regular, and there's no long-term fertility effects. And this is really looking at well over a year of information. Okay, next slide. The next concern is that COVID vaccine can give you COVID-19. I addressed that earlier as well. You cannot get COVID-19 from the vaccine. The vaccine will not make you test positive on a COVID-19 test. So the vaccines do not contain live virus, and there's no viral shedding after vaccination. We do have some vaccines in our world that contain attenuated live virus. So it's actually a live virus, but it's much, much less dangerous than the true virus. And that's what gives you the immune response. So like our chickenpox vaccine actually has attenuated live virus in it. It gives you a response so that you're protected if you actually meet chickenpox. But there is some concern of viral shedding after that. So that's why we don't give live attenuated viruses to people who are in their first trimester of pregnancy, for example. COVID-19 vaccine is not one of those. And again, the COVID vaccine cannot change your own DNA. Next slide, please. The next myth, and I think we have one more after this on our slides, is that people who've already had COVID don't need to get the vaccine. The question around natural immunity is a really tough one. And I know that it's really frustrating to a lot of people. They feel like they had the disease already, they recovered, they're doing okay, they're not going to get it again. COVID-19 is not like measles, right? Measles is a disease, you get it once, you do not get it again. We do know that people who have COVID-19 do get it again. And we know that we're not good at predicting who those people are. So natural immunity is variable. Some people seem to have a strong response and some people don't. And that is not predictable at this point. Similarly, antibody tests that look for antibodies to COVID-19 do not clearly tell us if you are immune or not. There are a lot of false positives in the antibody tests, a lot of false negatives, and a lot of variability across different antibody tests that are out there right now. The antibody tests really are not showing us yet to be a good marker of whether you're immune or not. The vaccine studies looked at some antibody responses, but we're also looking at large population scale efficacy. And the vaccine, we know, shows a stronger immune response than natural infection does, and it shows greater efficacy over large scale studies, and it's predictable. People respond to the vaccine in the same way, and we can be assured that it leads to similar immunity amongst different people. Next slide, please. We can address any more questions you have in the question and answer section, but I'm going to talk a little bit about how we are doing with vaccination rates in Clackamas County. So this is a slide put together by our Clackamas County epidemiologists. It's not 100% perfect. There are some estimates of the denominator, so the number of people who are in each of these age groups, but it's pretty darn close. We're doing a good job. 80-year-olds and older are highly vaccinated, as well as the 70 to 79-year-olds. The 12 to 17-year-olds, we're at nearly 70% right now. 70% is good. 70% has been a goal for a number of things, but 70% really we're finding is not going to give us that herd immunity that we need in order to decrease the number of cases that we're having each week, decrease the hospitalizations and the deaths that we're having each week, and get us back to normal where we can start taking our masks off and start socializing without being concerned about the spread of disease. We don't have a set number of where that herd immunity is, but we're looking at 80% or more. So in order to decrease the spread amongst our adolescents and protect our whole community, we need to get that 68.8 much, much higher. Next slide, please. This is a map of the teen vaccination rates in Clackamas County. So these are the percent of youth aged 12 to 18 who have had at least one dose of the COVID-19 by zip code. And you can see it's pretty variable across the county. The darker colors are higher vaccination rates. So 97034 is over 90% at 92.2%. The lighter are lower vaccine rates. You can see 97042, it looks like, is at 20.9. So a wide variety across our county in our adolescents, and that's true in the adults too. Next slide. Some of our upcoming teen vaccination opportunities. So we are really focusing on adolescents and teens separate from our general adult vaccine clinics. We want to make sure that kids have access to the vaccine in places that are acceptable and accessible to them. So local pharmacies will all vaccinate kids 12 and up. School-based health centers in many of our high schools have vaccines. And we have some Clackamas County, well, basically my team of nurses and amazing support staff doing vaccine clinics at, or others who are supporting at Gladstone High School in November and December, and Oregon City High School, November 13th. And you can always check our website because it's changing every day. We're adding more and more opportunities that are teen focused and soon to be youth, even younger focused on our website. Next slide. So can you get vaccinated at your own pediatrician or primary care provider? Maybe is the answer to this. So I work at the Beaver Creek Health Center in Oregon City, and we do have vaccines there for any age. You have to set up a certain special vaccine appointment for the kids. Others, you can get your vaccine, for older adults, you can get your vaccine at your normal clinic visit. But not all medical providers are set up for individual vaccine appointments in their office. And there are a number of reasons for this. So many vaccines come in single dose vials. All of the COVID-19 vaccines and the Pfizer come in multiple dose vials. So it's really hard to open one of those if there's only one child getting the vaccine that day. You have to know that you're gonna have a certain number of vaccines to give in order to open those vials and waste precious vaccine. It's more efficient to vaccinate at sites with high throughput. But many of our systems are moving to provider office models for boosters, and we're really looking at making safe and familiar places for the younger kids to make sure that it's that they feel comfortable getting vaccinated. So most places are higher throughput places. I know Kaiser has a parking garage where they give vaccines. Other places will do it in vaccine clinics, but just when you go for your well child check, the COVID-19 vaccine is likely not going to be available. You can always check with your provider. Clackamas County also has smaller clinics and an in-home vaccination program, excuse me. And we are coordinating with local school districts to provide school-based vaccine events. Next slide. A couple things to know before you go into a vaccine appointment. So the vaccine is available to everyone free of charge. You do not need health insurance or a social security number. You can receive the vaccine regardless of your immigration status. You don't have to live in Clackamas County to get a vaccine in Clackamas County and otherwise. So anybody can get a free, safe, and efficient vaccine right now, effective vaccine. You will likely need to wait in the clinic for 15 to 30 minutes after each dose. We do have a monitoring period. Most people wait for 15 minutes just to make sure there is no acute allergic reaction. We had a big concern about that early on because it was new. After a year and a half, very, very few actual true allergic reactions are happening, but we still have that 15 to 30 minute monitoring period. So Pfizer vaccine is a 2-dose series. So you have to go 3 weeks apart and get your second dose. Strongly recommend you come back for that second dose. That's where your true immune response really gets boosted and gives you that high efficacy. Your full protection begins 2 weeks after that second dose when your immune system has built up the antibodies and the immune memory. And Pfizer is the only one approved for 12 to 17 right now. So make sure if you're signing up for a vaccine event that they are having Pfizer vaccine there. Next slide. Minor consent is something really important for us all to know about. Oregon state law gives 15, 16, and 17-year-olds the ability to consent to their own medical care if provided by a physician, naturopathic physician, dentist, physician assistant, nurse practitioner, or an optometrist. Pharmacists are not included in that. A person operating a COVID-19 vaccination administration site, as the county does and many others do, and staff at the vaccination site are prohibited from requiring parental or guardian consent for a minor aged 15 to 17 by Oregon state law. If they're exercising their right to consent, we are prohibited from requiring any parental consent for them. Providers can use their discretion on requiring the parent or guardian to be physically present or available to answer questions for the 12, 13, and 14-year-olds. So those kids always need to have some form of consent from their parent or guardian. Whether they need to physically be there is variable from clinic to clinic. Next slide. So why get vaccinated? I'm going to wrap it up here, I think. The COVID-19 vaccines significantly decrease your risk of getting COVID-19. We do have breakthrough cases, but they are rare compared to those who are unvaccinated. It decreases your risk of getting the disease. COVID-19 vaccines help prevent you from getting seriously ill if you do get COVID-19. So it's rare to get it, and it's even rarer to get seriously ill or die from it. COVID-19 vaccines significantly decrease the risk that you can spread it to others if you do get COVID-19. So even though there are breakthrough cases, we're finding that the breakthrough cases are actually less infectious and their infectious period is shorter. So if you do get it, your chance of spreading it is also lower than if you are not vaccinated. And one of the biggest things, especially for our teenagers and our kids, is that fully vaccinated individuals do not need to quarantine if they are exposed. This means that they can stay in school. This means that they can continue to socialize as much as is safe, and you can continue your in-person learning. So when we think about the effects of this pandemic on kids and the need to stay home, and we have a way that we can prevent any quarantine time by being fully vaccinated, really want to encourage everybody to take that opportunity to keep those kids doing what they love to do. Next slide. Just a few more things. Getting vaccinated, even if you're a young person who's not likely to get super ill, protects your older family members, other community members, and peers who might have a higher risk of getting COVID-19 or are unable to be vaccinated. So our 5 to 11-year-olds and lower than age 5, they don't have a vaccine yet. Our 12 to 17-year-olds need to get vaccinated to protect their younger siblings, to protect the elementary school kids. You can get back to socializing and other activities. If we get down in our cases, we can take our masks off. We're not anywhere close to that yet. We're still in extreme risk as far as our county case counts. We need to get that down if we want to get back to normal. And then younger populations really play an important role in preventing the development of additional variants and reaching herd immunity. So decreasing the overall spread of the disease and the number of people who have the disease decreases the chance that the virus will mutate again. Fewer cases, fewer chance for variation. Fewer cases, fewer chance of mutation. So to prevent these variants that may be more deadly, like the Delta, we need to decrease the overall spread of the disease. Next slide. Looking ahead, we do anticipate emergency use authorization of Pfizer to expand to ages 5 to 11 as early as next week, although realistically we wouldn't have it available to give until early November. And again, the vaccination gives us a hope of return to some normalcy. It's the best tool that we have in combating COVID-19. In the meantime, until we bring our cases down and we decrease the spread and decrease hospitalizations and deaths, we need to continue our safety measures to keep the virus from spreading even more. We need to continue to stay home when we're sick. We need to continue to keep our exposures and our gatherings small, and we need to keep masking until we really get this virus much more under control than it is. Next slide. All right. Thank you for tolerating all that information I just threw at you. I would love to answer some questions.
All right. Thank you, Dr. Present. And now, as we stated before, we're going to move into the question and answer portion of the event. Here's how you ask the questions. Please go ahead and use your chat function at the top or bottom, depending on your device. We ask everyone to please keep your questions to under 30 seconds when read, as we would like to get through as many questions as we can. We've had several come in already. Thank you for those. The longer the question, the less chance I have of relaying it. Again, we are trying to get through as many as we can. All right, first question. Dr. President, if the research for vaccines was able to be accelerated, why was research for early treatments to avoid hospitalization also not accelerated?
I would suggest that it has been accelerated. So there have been a number of potential therapeutics that have been tested. Unfortunately, until very recently, we haven't found any that actually work. So as soon as we started seeing widespread transmission of this virus, people started looking at vaccines, other people started looking at therapeutics. Those people who've been looking at therapeutics, like I said, tried many, many things and none of them panned out. What has panned out is monoclonal antibody treatment. So that is actually an injection under the skin or in your vein of antibodies that were synthetically made. While that decreases your risk of being hospitalized by about 50% compared to the 70 to 90 to 100% decrease of hospitalization from vaccine is still the safer way to go. There are also potential side effects from monoclonal antibodies. There is a potential upcoming FDA approval of an oral medication, which I'm really excited about. That could be something like Tamiflu, where flu vaccine decreases flu to a point that it's a reasonable endemic thing. We see it every year. We know that people die from it. Every year we have 10 to 50, 60,000 deaths in the United States because of flu. Again, compare that to 730,000 deaths from COVID in the last year in the United States. But still, we use both vaccine and Tamiflu to decrease spread and death from vaccine or from influenza. If we can get COVID to a point that we have both vaccine and an oral pill that you can take if you've been exposed to decrease risk of severe illness, then we might be able to get it to where COVID is kind of like flu and we can actually live with it and tolerate the effect on our population and our health systems.
Okay, all right, thank you, Dr. President. Next question. Are you aware of other countries who are not recommending vaccines to this age group? And I assume by the age group, we mean teens.
Yeah, no, I'm not aware of any other countries that are not recommending it for this age group. There has been some question about whether vaccines should be used for this age group when so much of the world does not have access to vaccine for the older and more vulnerable people. There has been questions, honestly, about whether it could potentially cause more harm than good. And when really you dial down into the data, that's just not the case. Yes, there are potential side effects from the vaccine, but we are finding more and more, even within this age group, that they are incredibly safe. And the harms do not outweigh the benefits of decreasing spread in the community. But it was a big question. Do we vaccinate our kids, or do we ensure that the entire globe of older adults has vaccine? That's a big question that I don't have the answer to.
Okay. Thank you. What about another question? What about women who have experienced missed periods after being vaccinated?
Yeah, so like I said, there is a strong immune response that people have to the vaccine. That's a good thing. That is what causes some of those short-term side effects, because the spike protein is something that our immune system seems to really hate. So when you get COVID-19 when you get COVID-19 disease, the immune response to the disease is so high, the inflammatory response is really incredible compared to other viral illnesses like this, causing clots, causing cardiovascular disease, causing strokes. So the disease causes lots of these things. And a lot of that has to do with our own immune inflammatory response to the virus. The vaccine also gives us an immune inflammatory response that causes some of these side effects. It is a safe response to have, and it's transitory, and it builds up our system so that we don't have that huge response to the disease that can actually harm us. So when immune system gets overwhelmed and causes enough inflammation that causes harm, that's what we are preventing with the vaccine. So in times of stress, many women will miss periods. This is an immune response. It is a temporary inflammatory condition, and some people have found temporary changes in their menstrual cycle. They have not shown to be long-term. It has not been shown to cause any fertility changes, and it has been shown to resolve. So it is a safe and okay potential side effect, but it's actually a very, very, very rare side effect, even when it does happen. It's very rare.
Okay. Let me see. I think I'll read these two sort of together. I hope they relate to each other. You're the expert, I'm not. First was wondering about the possible heart problems with the Pfizer vaccines. If you are going to experience this side effect, does it show up right away or over time? And then the other question I'll add to it that we've got, which may be related, I think. You have left out the concerns of, I'm sorry, myopericarditis. I can't say.
Myo and pericarditis, or myopericarditis.
Yes.
I have left it out.
Okay.
Excellent.
So you have left out the concern. Well, sorry, I'll just finish the question real quick. You have left out the concerns of that in young males, which includes those up to 30 years of age. Statistics show that the risk of these adverse events are greater than serious outcomes of COVID in the younger age groups. So those two things together about the heart programs and that heart problems and that. Thank you. Sorry.
Yes, thank you. It is something that I probably should have had a slide about, but thank you for asking. So there have been some episodes of myocarditis or myopericarditis or pericarditis. That is an inflammation of the tissues around the heart muscle. I'm going to use the term myocarditis to include all of those. It's incredibly rare, but is a known response to a number of viruses that we have in the world. Sporadic cases of myocarditis do occur in all age groups, and after viral illnesses, they tend to be more. We oftentimes don't catch them because oftentimes they're very mild. Again, we're doing incredibly detailed reviews of the safety of this vaccine because it's just under such high scrutiny, which is really good because then we can find these safety flags, really evaluate them, and determine if the risk is high enough that we need to adjust what we're doing in vaccines. So it has been evaluated. It continues to be evaluated. There is no doubt in the scientific community at this point that the benefit from vaccine highly outweighs the potential very, very small risk of myocarditis, especially in young men. So young males have been shown to have a higher risk for this as a potential side effect from the vaccine. It does occur within the first couple of weeks, so usually about 2 to 3 weeks after the vaccine. It can be some chest tightness, some difficulty breathing, maybe a little arrhythmia or feeling like your heart's kind of out of whack. I'm not aware of any deaths from this response. There have been some people who've been hospitalized. They all have responded pretty well to NSAIDs, which is basically like super high dose ibuprofen. It's an anti-inflammatory. Similar to the change in women's menstrual cycles, the cause of the myocarditis after the vaccine is thought to be due to our own immune response and the inflammatory condition that it causes. So anti-inflammatories are treating the vast majority of these. There have been a couple of studies that came out actually this week that I want to look at here. So young males with COVID-19 infection had, so that same age group up to age 30, and this is a study that I just saw this week. I don't know if it's actually in print yet, but it will come out soon. They looked at myocarditis from COVID infection compared to myocarditis from COVID vaccine in this younger age group. I believe it was 12 to 30 years old. Sorry about that. I don't have the actual ages, but we can get you the reference. Young men infected with the virus were 6 times more likely to get myocarditis than those who got it from the vaccine. So myocarditis from COVID-19 infection occurred as high as 450 cases per million in the young men. It is 6 times less than that from the vaccine. So even though the vaccine can cause myocarditis, the chance of getting the same thing from getting the disease in the same age group is 6 times as high. The benefit of getting a vaccine outweighs that risk. There's also a look at our VAERS reports. Risk for males under 30 was about 10 times that of men over the 30. Highest age group a risk was the 12 to 17-year-olds after the second dose. Still, it's so incredibly rare, and it's so treatable that the benefit of vaccine is thought to highly outweigh that risk. I saw another report actually that showed that the peak age for myocarditis was about 20. It might be worth considering men 18 to 30 years old get the Johnson & Johnson vaccine. That hasn't shown this. I think that people in this age group who are concerned about it really need to talk to their primary care provider. We're getting lots and lots more research about it. And while it is a known side effect that is higher than baseline potentially, it's still incredibly, incredibly rare and has not caused any really severe or long-term deaths or problems.
Okay, thank you, Dr. President. Next up, any estimate on when the COVID vaccine will be available for 5 to 11-year-olds?
Yeah, so we're thinking as early as the first week of November. We actually were able to put in an order for Pfizer vaccine for 5 to 11-year-olds, even though it's not been approved yet. We are ready to receive it and start spreading it around to the community as early as probably the first week of November. It might be a little bit longer. The vaccine approval process has to go through a few steps. There's the FDA approval, then the CDC's immunization practice board has to review it. And then it needs to go to what we call the Western States. Sorry, I don't have the name in my mind at the moment. The Western States Review Board, which looks at Oregon, Washington, and some other states to make the final recommendations. And then we need to get our orders in place and make sure that we have the right materials. We do know that the Pfizer vaccine for a younger age group is thought to be a much lower dose than for adults. So, and have a similar side effect profile, if not better. So potentially fewer side effects in the younger age groups.
Okay. I'll put these next two together. My apologies, doctor, if you've sort of covered this, but I wanted to be sure to relay it. Again, these two are very close. Can you describe the use of monoclonal antibody as a treatment for those infected by SARS-CoV-2? Another question, why is monoclonal antibody treatment not widely available in Oregon?
Yeah, so I'll answer the second question first.
Okay.
There is a national shortage of it, so it is something that's similar to vaccines early on when there was a large demand for it. The production does not meet the demand at this point, so states are being allotted certain amounts depending on certain factors, including the disease spread and our hospitalization rates. So we're only getting certain amounts per week because of not enough production. The other thing is that it's complicated to give. So until initially, it was only done through IV that has to last over about 30 to 60 minutes, and then you need to be monitored for some time. Most outpatient clinics have not been set up to do that. We can do it subcutaneously, and there are outpatient clinics that are doing the subcutaneous monoclonal antibodies now. It's 4 different shots under the skin, usually in the abdomen, of about 0.5 milliliter. And then you have to be monitored for a certain period of time after that to make sure that you don't have an adverse reaction to the treatment. It's approved for certain people who are really at high risk of being hospitalized for COVID-19 disease after they are known to be infected or known to be in close contact. So similar to how we use Tamiflu for influenza, if you know you have it, you can take the medication and you have a lower risk of having severe illness. Or if you're in certain high-risk situations and you like a long-term care facility or nursing home, and you know you've been exposed, then taking it before you have the disease can prevent you from getting the disease. Monoclonal antibodies are similar, but they're much more involved in that you have to do it through the IV or subcutaneously, and it's not like widely available because of production and because of the expertise and certain clinical settings that need to be set up specially in order to do it safely in the outpatient setting.
Okay, we got a few more minutes, and I think we've only got 3 more questions, so we're going to end right here at 7 very quickly. Dr. Present, why have you not mentioned the data from the VAERS, Vaccine Adverse Events Reporting System, that is capturing adverse events?
So VAERS is first of all, I'm gonna make a note that I am commenting on it. So a lot of the safety concerns that we found, like the myocarditis, like looking at hospitalizations and deaths after vaccine, a lot of data does come from VAERS. The thing about VAERS is that anybody can enter a report, right? So each report of a severe illness has to be really evaluated to see if it's actually a true illness, a true response to the vaccine, and how severe it actually is. So each VAERS report needs to be verified. There is a lot of data out there, but we know that anybody, various levels of providers, various people can put in VAERS reports. And so that data really needs to be sifted through with a careful eye. People enter information differently. I did look at deaths after vaccine from VAERS. And so there were more than 310 million doses of COVID-19 vaccine from December 14th to June 21st. VAERS received 5,343 reports of death among those people who received the vaccine, but actually in verifying it, it was 0. So if you leave a vaccine clinic and you get in a car wreck and that car wreck kills you, that is a death after a vaccine that I, as a medical provider, am actually required to report. That death is not from your vaccine. That death is from the car wreck, but it still shows up as a death after the vaccine. So there's a lot of nuance to VAERS, but it is the way that we find those safety flags. So like the myocarditis, like the clots in J&J, that information did come from VAERS. As soon as there was a tick of like, oh, might be something, there's a pause and a really, really close review. So I am referencing a lot of information that's come from VAERS, and we just have to know that there are challenges to that information.
Okay. Dr. President, is it okay with you? We do have 2 more questions, and I know we're at 7, but I think we can get through them, and then we're going to get through everybody. Is that okay?
Okay.
Okay. This next one is a 2-parter, really. They're both about masks. How do you respond to the difference in mask protection being almost 0 with cloth masks when many kids are still wearing cloth masks at school? And then the related one is, OHA has cases down to levels in August when masks were not required out of doors. Why are kids still wearing masks outside when it is documented that people do not spread this disease when outside, especially when children are being screened for illnesses before being sent to school? So really about cloth masks and outside wearing masks.
So I'm going to look at the second one first. Clackamas County for sure is not back to where we were in August or July before the Delta surge. So we do have a long way to go before we get to the lower levels where we were really starting to loosen restrictions before the Delta surge came. Really, we have a risk level of low transmission as being under 50 per 100,000 over a 2-week period. And that's kind of what we've thought of as like when we can go back to not masking potentially. The difference in different types of masks has been a pretty awful communication system from the public health system throughout this pandemic. I totally acknowledge there's been a lot of confusion about masks. Early on, the CDC was saying, no, you probably don't need masks. We really pretty quickly found that that wasn't true. I acknowledge that the communications around masks throughout this pandemic has not been great. Communications around lots of things in this pandemic have not been great because we have to change it so often as we learn about this really new, really different virus, really different from anything that we'd seen before on this scale. So at this point, a good cloth covering that has at least 2, if not 3 layers of cloth that is well fitting does show to have protection against spread in community when everyone is masking. So there's some source control, some infection control from others. Maybe not as good as an N95 tight fit seal, but that is not tolerable to wear and manage, especially for young kids throughout the day. So cloth masks do offer protection. A cloth mask does not mean a lace mask. It does not mean a mesh mask. And we do see those sometimes, and those don't offer protection. And also it's important that it fits tightly to the face. So cloth masks with big gaps on the sides, they don't offer the same protection. So, but we are finding that the risk of transmission in schools with kids who are wearing well-fitted, consistent masks, the risk of transmission in schools is incredibly low. As far as kids wearing masks outdoors, so outdoor masking was a mandate that was put back into place with our Delta surge. We are on the other end of that. I do anticipate that outdoors we should take our masks off again soon, but it's really that, especially when we're trying our hardest to keep kids in schools, in person in school, the safest thing to prevent transmission is just to keep the mask on because it's so hard to know who they're really closely interacting with. For right now, until we get our case rates even lower, it's best to just keep the mask on. We'll get our case rates down and then we'll start taking them off, sequentially. Yes, starting with outdoors. Risk of spread outdoors with spacing is pretty low. If you're playing really closely with another person outdoors, you can still sneeze on them. You can still breathe directly in their face, and that risk of transmission is higher. And we're really trying to help our school systems limit confusion around who's exposed or not. We need to just make it really clear.
Okay. Thank you, Dr. President. We'll get you out of here right after this next one, and that's it. That's a good one to end on. What can you say to those of us that know vaccines are the right thing to do, but are very scared about giving it to our children?
I can say that is incredibly natural. So as you know, I am a parent myself, and when I was pregnant with my daughter, I did a lot of my own research on vaccines. I didn't just Google them though. I looked at the initial, primary research, and I've been trained over years and years of medical and public health school to be able to read those studies well. I had concerns around lots of vaccines at the same time causing allergy. I found that the trend was actually that it lowers it. I found a lot of things in common media that were not actually the case when you look at the original research. So many people did not go and get the vaccine right when it was available. Many adults didn't. Many people wanted to wait a month or two and see how things went. If you're pro-vaccine and you want to wait a month, it's a reasonable thing to do. I'm a public health doctor. I want this pandemic to end. I want everybody to get vaccinated as quickly as possible. I'm super excited to get my daughter vaccinated as soon as we can. And she's super excited about it also, because I feel really confident that it's going to be safe for her and for other kids her age. And I think just knowing the comfort that your child will have about not being afraid of having to quarantine, not being afraid of being exposed in schools. There's so many safety measures in the schools right now that cause stress for our kids. The vaccine is safe. The trials for children is lasting much longer than the trials for adults to ensure that, so that we don't have to wait those few months to kind of wait and see once it gets into the bigger population. They're actually longer trials for kids. And the decrease of stress that it can cause them in this world of stress we have, I think is worth it.
Okay. Thank you very much. I want to thank Dr. Sarah President for joining us for the hour, and my apologies to you, Dr. President. I'm sorry that I kept you 6 minutes later, but I think we did get to all of the questions that were posed by the time that I that I said we were going to end. So my thanks to you. My thanks to everyone for joining us tonight. We have gotten the questions about where this will be posted. The recording will be posted. It's in the chat to our COVID vaccine website. That's at clackamas.us/coronavirus/vaccine. So for Dr. Present, I'm Dylan with Clackamas County. Have a good night. Thank you very much.
Thank you.